At this time, I'd like to introduce you to our speakers. Dr. Schutz has worked in healthcare for over 30 years, was a rural hospital CEO for 17 years, and now teaches healthcare administration at Elms College in Chicopee, Massachusetts, where he is the director of the healthcare management program. He received his doctorate in public policy from the Nelson Mandela School of Public Policy. Mark has published journal articles on hospital policy implementation, healthcare policy development, and presented at numerous conferences as a professor and administrator. Mark's professional interests include governance, organizational performance improvement, and rural health policy. He is an experienced clinical social worker and registered health information administrator. Terry Hill is Executive Director of Rural Health Innovations and Senior Advisor for Rural Health Leadership and Policy for the National Rural Health Research. Terry has more than 30 years' experience in working with rural health leaders. He facilitated national summit meetings, written dozens of published articles, led national demonstration projects in rural health, and helped to develop multiple national healthcare delivery models. He has been teaching management and leadership for the MBA program at the College of St. Scholastica for 11 years and previously lectured at the University of Minnesota Medical School. He currently serves on the board of directors for the National Rural Health Accountable Care Organization. Now, I'll turn it over to Terry and Mark.
Well, thank you very much, Kim, and welcome everyone. The topic of the day is rural strategies for transitioning to value-based purchasing and population health. Let me say that, first of all, this presentation and all of what you're going to be hearing today is a part of our small rural hospital transition program that is funded by the Federal Office of Rural Health Policy. And that program basically enables rural health innovations in our center to work in rural communities, pretty much particularly in poverty areas that are medically underserved, et cetera. And the program started out in the Mississippi Delta, where for I guess it was about 11 years we worked with rural hospitals in an 8-state area. So the program itself basically made a transition from what was just a very intense focus on improving quality and financial performance of rural hospitals in the Mississippi Delta to one that includes to have that focus, but now has a new focus, which is on helping rural hospitals transition into the new value-based payment models and into population health management, which is also kind of a part of that formula. One of the things that I learned a long time ago, both in real life, working in rural hospitals, but also, in my MBA background, is that finance tends to basically lead form and function. And that in essence, in the past, our financial system paid us. The form was, we did a lot of sick care, we did fee-for-service. Our model, our business model, basically, both the form and the function, was focusing more on treating patients once they got sick, and there wasn't a whole lot of focus on prevention and wellness, et cetera. So this transition into a new era, which we're going to talk about today, basically is driven by the new financial models that are coming up. So for that reason, it made sense to convene a group of experts, folks that are actually in the field, so to speak, folks that are advising the hospital leaders in the field, and then some representative of state organizations as well. One of the first things we did is to say, okay, we need to put this into some sort of a written form, and what made most sense to us is to basically enlist somebody like Mark Schutz, who used to be a rural hospital administrator. I know I worked with Mark years ago in Louisiana, and he's now at Elms College in Massachusetts. So we thought Mark would be kind of a perfect person to do this, because he's got the background. He can speak rural hospital language. This is not intended to be, you know, kind of an academic report. It's to reflect kind of the wisdom of this group that we put together. Mark, I'm going to ask you to say a few words about kind of what was your interest here, kind of reflect your experience broadly as you work with this group that we convened in April of this year.
Thanks, Terry. You know, one of the things that I've always tried to focus on, even in academic work, is trying to do things that are meaningful and helpful to people. And I certainly saw this as an opportunity to do that, because I know as a rural hospital administrator, we faced so many challenges, and to me, a lot of the challenges we had was lack of information. And so it's, I think, so important that folks out there in the rural areas, fighting on the front line, so to speak, have the best possible information they can. And so I was really just so pleased to see there be a practical approach to this project, and that we actually brought people in, both from the consulting side and those from working currently in hospitals, to try to put them together and come up with just some relatively basic ideas and helpful hints, so to speak, that administrators can actually take away hopefully from this conversation, or at least maybe begin to explore if they need more information, and there's certainly more information out there. So I want to applaud the folks who are funding this and the folks who participated, because I hope that those in this program and other folks who read this work will take something valuable away.
Yeah, thanks, Mark. And I'm going to kind of lead this presentation, so we're not necessarily going back and forth all the time, but I'm going to also invite Mark to kind of jump in here, and I'll ask him questions as we go through here as well. So first of all, for those of you not familiar with the National Rural Health Resource Center, we've been around quite a while. We've had kind of federal contracts since 1995, and we have 5, we're basically humbly calling ourselves the nation's leading technical assistance and knowledge center in rural health. We have 5 areas of focus. The first one, as you can see, is transition to value and population health. It's going to be incredibly important that rural providers find their place in the new healthcare system, and so we have made a special focus here on this transition into value. Collaboration and partnerships, we support networks across the United States. Been doing that for quite some time. The performance improvement, a great deal of that comes out of our small rural hospital transition program. We also have the Task Technical Assistance and Services Center and support 45 state Medicare Flex programs. We do health information technology. We're a regional extension center, and we've had a workforce. We've kind of been the workforce center or the major recruitment and retention agency in Minnesota for, gosh, it's been about over 20 years now. So with that kind of as background, these were the objectives. So we brought these people, and I'm going to talk about them just a minute. We said, let's discuss some of the forces driving these market changes. Let's look at it from a financial standpoint. So if you're a financial leader, you know, what are those forces, and you know, kind of how can we capture these in the kind of the financial bottom line terminology? Let's look at strategies that the panelists are using. We just had some really, you know, they're kind of industry leaders in rural hospitals here, besides some of our best-known consultants. And let's look at some specific hospital examples, and let's see if we can build the awareness of available tools and resources that support rural hospitals for population health as well. So the object here is to put something into place that's readable, that's relevant to rural hospitals, that is not going to be an academic report, but is going to be kind of a shared wisdom and shared recommendations for strategies. Now, the Financial Leadership Summit is supported by the Federal Office of Rural Health Policy, and our project officer is Janine Myers, and Janine has just been a tremendous kind of leader of this program. She works with us in strategy development. She's just been terrific to work with throughout. And I know that Mike McNeely is on this call as well. And Mike actually is kind of the deputy leader of the Federal Office of Rural Health Policies look at hospitals. So Mike, could you say a few words basically about why the federal office decided to fund this, and anything else you might want to comment to open here?
Yeah, Jerry, I appreciate it. I just want to say that this type of work is inherently valuable when it comes to how we're looking at the current healthcare environment, as well as what we're looking at for the future. There's one thing that is readily apparent, is that the value proposition is not going to go away. And specifically that no matter what happens in the upcoming year, this idea of changing from volume to value will continue. It was initiated by third-party insurers. It was adopted by CMS, and going forward, it is an economic driver because the responsibility on the hospitals going forward will be looking at preventive medicine and population health in general. And because of that, there's a lot more stress on hospitals. So when we look at the finance side of things, it's key that we understand what limits and what challenges are being faced. One of those things that is inherently valuable and which has put more burden on the hospitals and has put more burden on the federal government is the need for data to back up these challenges. Everything is driven by the evidence base as we move forward, and in collecting accurate data and using that data to inform decisions has become a prominent idea within the federal government, and more specifically within the federal office. We really trying to drive programs as it relates to data. And in this case, in the transitions program, it's data-driven based on need, as well as areas that have been identified as persistent poverty. But the lessons that are being learned, even through this Financial Leadership Summit, is more applicable across our office. We look at this as informing both our Medicare Flex program and our Small Hospital Improvement program, because the lessons are translatable. So we appreciate the work that has been put in by the volunteers that worked on this, and for the work that the center has put forward. With that, I know Janine appreciated the commentary that you made about her, though she refuses to speak at the moment about the subject. But she is listening to this. So with that, I'll pass it back to you, Terry.
Yeah, thanks a lot, Mike. And that's really important to stress here, is that the Federal Office of Rural Health Policy, see these initiatives as something they contribute to. They're not standing over us with a big stick or saying you have to, adopt this or that, et cetera. It has been very collaborative, and I just really want to acknowledge them. They are kind of our shining star within the federal government, and just over the years, they have made huge contributions. They speak when they talk to CMS, or they talk to the Office of National Coordinator, et cetera. I mean, they speak on behalf of us. In many ways, we're really happy to support them as well. This was our stellar group of folks that came together, and it's about the kind of a typical size. We met for 2 half days in Minneapolis. We've had a variety of other types of meetings. We've held National Summit meetings on quality. We've held them on health information technology. We've held them on population health. And so this is kind of a continuation of a pattern that has kind of emerged and with the Rural Health Innovations. These folks represented 11 different states overall, and I threw Mark in there because he's now living in Massachusetts, but he also had kind of input here from his scribe role as well. So they were pretty much there were representatives of the state offices of rural health. I think there were 4 CFOs. There were 2 CEOs, and again, generally from different states. Because we wanted this geographic representation, we had representatives from Ide Bailey, from Stroudwater, and from various other organizations like Whitley, for example. Jeff Johnson was there, and Brock Slabaugh from the National Rural Health Association, also former president of the National Rural Health Association, Lance Keilers, et cetera. So it was a really good group, and it's a structured dialogue. Sally Buck and I basically did the transition work here as we kind of helped to guide that conversation. So this is now you're going to get exactly what came out of here. Market forces, we asked the group, what market forces are you seeing kind of driving this industry towards population health? The triple aim came up. It's about better quality, better health, and better and more reasonable cost here. And we also looked at mentioned were the Affordable Care Act, CMS Better Care, Smarter Spending, Healthier People Initiative. In essence, the payers, the federal payers, Medicare and increasingly Medicaid are really moving in this direction, and that's a major market force. Remember, finance, drives form and function in this particular environment, so that was really crucial that we recognize that. We also kind of looked again at where CMS is putting up in terms of target. This actually came from Secretary Burwell. Rapid movement into value in population health. So the projection here is that by 2018, 50% of all payments are going to be in a kind of a value-based or an alternative payment model, and a full 90% are going to be based on quality and on cost, kind of that triple aim formula as well. Now, we've already hit the goal that Secretary Burwell put in terms of 2016, which was 30%. We're already over that 30% mark. So we wanted to just kind of reiterate the industry's moving, it's moving very fast, and the payment models are very clear in terms of where everything is going. I should have also mentioned MACRA here, and I'll talk a little bit more about that in a minute, which basically represents the brand new payment model for healthcare providers and physicians. The other forces we saw were commercial insurance plans with large deductibles, which really speaks to the need for efficient revenue cycle management. Very clear that we're not going to see more Medicare, Medicaid, and insurance payment money. Our payment rates are going, as rural hospitals are inevitably going down, and we already see that moving downward. Kind of elimination of the disproportionate share hospital. This increasing need for transparency of quality indicators. You can go online right now and check out the quality performance of virtually all physicians, hospitals, etc. This is not just Hospital Compare. It is just a lot of different kind of web-based available information and resources that are making quality very transparent for consumers. And we should mention, consumers are increasingly going to these websites, young and old. And my mother would never have gone in these places, but as I'm getting older, it's going to be the first place I look if I need to find a surgeon or I need to find a hospital and I have any choices whatsoever. And then incentives and payments, penalties based on quality as well. So these were some market forces moving forward. So much of it is just basically it's payment and then transparency in quality, and increasingly, as might be mentioned here, these responsibility for health outcomes. So what's impeding our rural hospitals? Well, for one thing, we have a lack of expertise out there. It's just what we're talking about very often is very technical. So we're going to have to look for ways to acquire the expertise that we're going to need. We're going to suggest that there are some collaborative things that can be done here, but the expertise is going to be necessary. Lack of board awareness of population health, we talked quite a bit about that. In some cases, competition from larger systems with their own insurance product. So larger systems are partly a solution, but they may also be increasingly compelled to come out into our market service area and try to take some of our market away. Inability to access, manage, and share emergency electronic health record data, and kind of the unrecognized, this was what I wanted to make sure we comment on, unrecognized value of quality of care provided on the financial statements. In other words, the financial leaders were telling us, when we make this investment into care coordination, into preparing for population health, it's not showing up as a positive on our financial statements. And oftentimes our boards don't recognize that, and instead of the stellar financial performance, we may be flat or even going negative here. But we are improving our quality, and that's going to be necessary in the future financial formulas, but it may be hurting us on the short term in the financial statements. Mark, I'm going to turn to you. Anything else that you see here as you kind of look at kind of what came out of there? Any other observations that you'd have on kind of what's driving us or what's impeding us?
Well, I think one of the key factors that the participating administrators talked about was the coming ability to really be able to do what rural providers have always wanted to do, which was really take care of the patient. Right? The incentives are changing so that now, instead of sending that patient home and maybe expecting them to come back in 30 days, that now with the way the incentives are moving, that there'll be a coordination of care and a much higher level of care that hopefully keeps that patient from coming back. And the fact that the patient doesn't come back actually helps the hospital instead of hurting them. So I think there's optimism about that from the administrators. I think that the other darker side is the fact that these changes, we've had 74 hospitals close or around there since 2010. And we're certainly lifeline or safety net providers out in the rural areas. And I think we just need to do whatever we can. We know, I think everybody there agrees that not everybody's going to make it through this transition, but I think as we can provide as much information as we can and give those folks who are out there the opportunity to really beef up their services and make decisions that are informed decisions.
And you know, Mark, that reminds me that the latest figures that are coming down from the University of North Carolina, which is our designated financial research center, indicates that the gap between rural hospital financial performance and urban hospital financial performance is getting bigger. In essence, the urban hospitals have tended to be slight financially, or at least holding their own, while our rural hospitals have declined in terms of financial performance. So as Mark said, already 74 hospitals have closed. And if we keep going on as we've gone, there's not a whole lot of light at the end of that tunnel. So I think the point here is that there's no safety sitting back in our rural hospital financial systems. We're probably going to be forced into these new payment systems, but we very well might be better off in them, and that's kind of what was part of our conversation as well. There is we're feeling pretty strongly that there is a value of rural hospitals in the new systems. Now, this is just like a force field analysis that helps us look at the fact that this is not just a linear sort of a problem that, you know, the feds made us do this, and then we're, you know, we're going to have to do it, and et cetera. There are all these forces that are acting, including the payment pieces, the demands for quality, consumers more kind of more demanding, et cetera, and shortages of providers. I don't think I have to go into them in any great detail. You can recognize there's a lot of drivers and a lot of transition challenges here as well. Now, we thought that if we had a number of different strategies putting together, and this has kind of been a fundamental kind of a concept from our center for quite some time, and I think it's also been supported by the federal office, and that is that putting a framework in place allows us to, kind of an organizational framework, allows us to kind of capture the key strategies in kind of one framework, and allows us then to manage them more effectively and kind of chart our progress moving forward. There were two that were supported here, two that were recognized as value, and I'm going to go into them briefly. The first is our performance excellence framework that the center has put in place, and this is really based on the Baldrige program, and it's kind of based on the premise that in order to produce sustainable results that are going to be excellent, that you really have to engage leadership, do meaningful strategic planning, work with your customers and your community, measure your feedback and knowledge, engage and educate your workforce, and do your process improvement as well, and then document your impact and outcomes. We have a ton of resources within the center. Almost all our programs are built around this type of a framework, which basically suggests that the solutions here are generally going to be multifaceted. This was a transition framework that was suggested by Eric Schell, who many of you may know from the Stroudwater Group, and they've been using this, and it was generally accepted by our panel. Now, I don't have enough time on this call to go into all the specifics here, but in essence, the message here is that we're going to go through various phases moving into this value-based future, and that a key strategy here is going to be making sure that our delivery system, how we're providing the care and what format, what processes, the delivery system is aligned with the payment system. So in essence, if we decide to move into some sort of value-based payment system while we're still getting paid, let's say, fee for service, or the old traditional way, or even cost-based reimbursement, we need to remember that we can't have a foot in both boats for very long. At least we call it kind of crossing the shaky bridge as well. That you've got to be very careful getting into that value-based future. And the first phase is recommended by Stroudwater here is plan, prepare for it. You don't have to leap into accountable care organizations, but you definitely have to think about them. You have to plan for it. And that middle piece is just basically you start to prepare for population health management, which this framework says is going to lead to provider-based health plans. In essence, the model of the future, according to this frame, is that a group of providers are going to have responsibility for the health and wellness of a group of it could be Medicare recipients, it could be entire communities. So a group of providers are going to take care of a group of insurance recipients, whatever it would be. So it's provider-based health care. And everybody pretty much agreed that this would, if it wasn't going to be the total payment on the back side of it, we're going to see these almost like Medicare Advantage type programs that are out there that will, kind of fundamentally be the last step, and that there will be a lot of population health management that will be a part of that as we reach that kind of final phase. And now there was some disagreement among whether that was going to be 100% of the payment. There were several folks who thought, well, it'll be a big part, but it won't be exclusively, et cetera. So, but they did support the framework itself. And you can go into more detail on that. We have some excellent webinars on our website, which I want to highly recommend to you. The Small Rural Hospital Transition Programs has presentations by Eric Schell that specifically lays out this roadmap, and I'm going to move on without saying much more than it's a very thoughtful projection of where the industry is going and what rural providers should do to get ready.
Terry, I think I'd just like to add.
Go ahead. Go ahead, Mark.
Add up. One of the really essential items is that, as you mentioned earlier, reimbursement kind of pushes form and function. That's really what that graphic points out, is that if we get ahead of ourselves, even rural or non-rural, as far as reimbursement, we're going to get ourselves into deep trouble. So really trying to continue to follow the money, right? So providers really have to say it. How are we paying now, and what's our expectation about the near future? And so what do we need to do to be ready for that?
Yeah, absolutely, Mark. So basically, one of the things we've heard in the past is you give us a bunch of strategies here. Which ones are we supposed to do first? So for the very first time in our summit meetings, we really divided this up into saying, if you're a rural hospital, these are the things we recommend as a group that you do as immediate strategies. We also had some that suggested that there were intermediate, and some of them were a little bit longer term as well. But let's first take a look at these immediate strategies. We had our group actually vote on these, and these were the ones that had the highest. First of all, they developed the strategies that I'm going to talk about, and then we said which ones are most important to do right now. And at the top of the list was the improved financial, clinical, and operational efficiency. We can't go into value bleeding financially. We can't go into value with low quality scores, because we will be penalized, and in in essence, we simply, we won't be successful, and we won't produce the value that's going to be needed. So the suggestion was do all you can right now to improve your revenue cycle management, your clinical operations, and kind of how you conduct your operational processes as well. You don't have to be perfect, but you can go in, like I said, with great deficiencies in any of those areas. The second piece, and this was really important as well, is engage and educate the leaders and the staff. The boards of directors really need to know what's going on and why the hospital is going to shift the way it does business, and why it's better for the community, why it's going to help keep people safer, healthier, etc. And the other reason for that is that basically board members become representatives in your communities, and you're going to see you're increasingly going to need the community to jump on board here and to understand this as well. And then finally, and this one was crucially important, we have to partner with our physicians and our other primary care providers, because the whole base of these new models are kind of right associated with particularly our primary care physicians. And with the passage of MACRA, which I just want to say a few words about, I do recommend you to go online and look. There are YouTubes available, or contact us and we'll send you information on this. But beginning in 2017, MACRA goes into effect, and it totally restructures Medicare Part B payments for physicians and other primary care providers, and NPs and PAs, etc. And it basically is going to put them into, one way or the other, all of them into this quality system and this kind of advanced payment model system. The only exceptions right now are our rural health clinics and the FQHCs, and they haven't really decided what to do with those providers, so I wouldn't hang out indefinitely here. But everybody else, all these other clinics and healthcare providers and physicians are going to have to move into these new models. Without the partnerships, our rural hospitals are really, really endangered here, because simply there will be tons of folks that are willing to take them in. For example, in MACRA, in the advanced payment model, there's a whole 5% bonus on your Medicare Part B payments if you're in these models. And we're anticipating, and other organizations are anticipating, that physicians are going to find much more financial value in the advanced payment models. When I'm talking about ACOs here and kind of medical homes and these sort of demonstration projects that are being funded by CMS. This is a very deliberate attempt to move our providers into value in population health, and we think the financial rewards are going to be compelling. Mark, anything else on that? Yeah, go ahead.
Yeah. Well, let me kind of flesh out a little bit information on these, because you say if I'm an administrator, you tell me improve financial efficiency. Well, I'm already working hard on that. So I think the paper has this in there, but we're going to a couple of things. For instance, we're looking at updating your charts faster, improving your revenue cycle processes, which you mentioned, initiating point-of-care collections. All of those have shown to help with your money, right? Help you bring in more money. The other thing was the use of lean. We're seeing that process used a great deal in hospitals. And there were some stories told from these folks that were at the meeting, a substantial money savings, as well as enrollment in 340B programs. A lot of rural hospitals, I know, have very little information about 340B, and if they do have information, they're not really sure if it's going to help them or not. But there's been some hospitals totally saved financially simply by adding the 340B program to them. So I think there's some things that are out there. The paper has more. I don't want to go into a whole lot of them here, but there are things you can do, and there's help out there if you need help getting it done.
Yeah, thank you, Mark. We're also going to be launching a portal from our small rural hospital transition program that will give you access to some very relevant information and tools and resources as well. But again, it's easier said than done, I realize, but they really wanted to make this point that it's not a strategy moving into value if you don't have your act together and these other pieces. Now, we put some in terms of short-term. I'm having difficulty with my clicker here. It's simply not moving. This is immediate. Okay, the short-term, I got it here. Short-term strategies, they're in this new payment model. The community health outcomes are going to be increasingly a part of the formula. So we need to get the community involved. We've got to look at what are the diabetes rates. If you want a good resource, you can come into our population health portal that the center launched a number of months ago, where you can calculate kind of community health needs best based on the best data available and some quality information as well. This may not be the time to throw all your effort and energy into wellness programs, but it is the time to start looking at your community health needs and perhaps begin to develop some wellness programs for your employees, for example. A second is identify available population health resources. We're going to need all the help we can get out there, and that again is why our center has put these new portals in place where you can get education, you can look at health information outcomes, you can look at a lot of data that might be available to you as well. Another strategy that is being employed by virtually all accountable care organizations right now, and those that are considering moving into accountable care organizations, are putting together care coordination and care transition teams. It's something that there is federal money available through the TCPI program. the Transforming Clinical Practice program. There's money available out there, and we really encourage you to look at seeing for ways and resources that be available for these transition teams themselves. And then the bottom line, and Mike McNeely mentioned this as we kind of started off here today, we've got to collect, manage, and act on patient data. It was mentioned that I serve on the board of the National Rural ACO Consortium. What I can tell you is that the early years of that accountable care organization, they were not able to realize any savings in any financial way. They dramatically improved their quality. They did lower costs substantially, but they failed to meet some of the quality guidelines, primarily because their providers weren't doing annual wellness visits. So there wasn't any bonus for this accountable care organization. What the hospital administrators and a number of physicians said the biggest benefit that they got was they were getting information now on their patients, their complete experience. If they were Medicare patients, they knew where they were going for tertiary care. They knew the quality of the referral centers, et cetera, et cetera. It was really, really important. And we're going to have to develop that capacity through some sort of either working with a larger system or working together with other hospitals to kind of make that happen.
I think, Terry, I would add that, one of the suggestions that came up about looking at community resources, I think one of the solutions that one of the hospitals used was partnering with the area EMS so that they were able to use those people to check on patients. In small communities, you've got EMS sitting around, not terribly busy all the time. And so if there's a resource in the community that can help you with the continuum of care, why not tap into it?
Yeah, absolutely. Kim, I've lost the ability to move my slides. Would you mind just moving them?
I don't mind at all.
Thank you so much. Yeah, it would be the longer range strategies.
This slide? Long-term strategies, Terry?
Yes. It's not even showing up on my screen, so I apologize. Okay, let's talk about let's talk about the long-range strategies. I'll look at my printout. And these weren't really that long. We were saying, in essence, these are things you need to think about, but you've got a little bit of time to do it. Collaborate with other rural hospitals and larger regional health systems. And in this particular case, it didn't mean that everybody has to join a system. We're seeing a significant increase in the number of rural hospitals moving into systems, but we're also seeing the development, again, thanks to grants from the Federal Office of Rural Health Policy, of a lot of new rural health networks. and those rural health networks basically are going to help to support, to develop, for example, the information that we're going to need in terms of the patient data, the capacity to do care coordination, et cetera, et cetera. So these are important things, and so it may be time now to get these started. If you're sitting out there by yourself, and our group is suggesting that you think about working together or joining another system. And finally, it was to document hospital outcomes and demonstrate value. The rural or the bigger urban-based accountable care organizations might not have reached out to you yet, but in essence, if you can show your value in terms of preparation for transition into population health, if you can show good quality outcomes, if you can show good financial outcomes, then in effect you are going to be able to be successful in this new system. If you can't document it, and it's like Mike said earlier, it simply is maybe you aren't going to find a place in the system itself. Rural hospitals are no longer going to be able to see themselves just as feeder systems, and I know they haven't necessarily, but that has been a part of their value, and that value is significantly diminished here. We're going to have outcomes, and we're going to have to demonstrate value. Next slide, please. So we're just wondering if you've got any thoughts about the most important financial strategies, anything we've missed here. Again, we have a lot of smart people on this call, and so we wanted just to throw that out there and either in the chat box answer the question to what other strategies could a rural hospital employ, and are there other opportunities existing for rural hospitals to close the gap to achieve these key strategies? So it's a little bit of participation here if you are interested. Either put them in now or do email them to us, email them to Kim, and we will gather them and provide them as input to this report. My clicker seems to be working now. So the next piece has to do with success stories, and this was really an important part, and I would really refer you to this this document itself. Just a few of them here. Rebecca McCain, who's the CEO of a hospital in Texas, talked about developing an internal care transition team with the intention to reduce readmissions. And one of the things she said is the key to successful implementation is receiving real-time data on patients. Not stuff that's months old or years old, but having kind of robust health information exchanges, or whatever you're going to be doing on that to get that as recent as possible. Larry Spurr, I know, is on this call, who's a CFO from a hospital in Illinois, really talked about the value of community needs assessment. And I really, for a CFO to be talking about that, I just found that particularly